I'd like to welcome you back to this session, and I wanted to introduce Dr. Gerald Chader. Dr. Chader is a Chief Scientific Officer at the Doheny Retina Institute and a professor at the USC School of Medicine in California. Dr. Chader worked with the team that recently had an electronic retinal implant that's been approved for use in patients with inherited retinal diseases. And he is also part of an investigation into the use of stem cells to treat dry AMD. So this is incredibly exciting. Dr. Chader has over 340 scientific publications and is the founding editor of Progress in Retinal Eye Research, the top-ranked journal for vision research. Today he will discuss possible treatments for dry AMD. I just like to welcome Dr. Gerald Chader, who is just a wonderful friend. Thank you.
Thank you, Sharon, very much. In fact, I am going to bring this out and hold it right here so you're all going to be able to hear me. I usually, I have about a half-hour talk now. I usually try to put people to sleep in the audience and myself as well. So hopefully this is not quite the case today. And I have to thank Dr. Brint for giving a wonderful, wonderful talk this morning. It was just a superb introduction to what AMD is and the current treatments, the different types of AMD that we have and all that you have here. And I usually start my lectures on AMD by saying that AMD is a complex disease. So what we're going to be looking forward to in my talk is what's coming more in the future. I'll review just a little bit, overlap, which I think is always good. Repeating is not bad. A bit of what Dr. Brint said on, say, some of the treatments for wet AMD in particular, but then move forward there into what's coming in the next few years and maybe even the few years after that. So we have a couple of layers of where we're going. So AMD, as you have heard, is a complex disease. It's almost as if wet AMD and dry AMD are two separate diseases. They're not, but the treatment regimes are. For wet AMD, of course, it's a very simple direction, as Dr. Brint told you, to stop what is called neovascularization, new vessel formation, new blood vessels that form in your eye. And so it's simply stop the neovascularization. For dry AMD, we have several options and all, which are not as well developed as you heard again just a few moments ago. But different pathways are available, and I'll review those and then look forward to a few more coming. But first, I want to repeat some of the stuff that Dr. Brint said, a little background, a little science background. We now do understand some of the factors that lead to photoreceptor cell degeneration, and this is the key here. It's the photoreceptors in your eye that are dying off because of either dry or wet AMD. And there are 2 or 3 causes for that. They're, again, complex, and we don't fully understand. One is immunological damage. It's now pretty sure that about at least 75% of patients with AMD have some genetic component. It doesn't mean that if you have a gene mutation you get AMD, but your possibility of getting AMD is increased considerably. And most of the genes that we have found that are involved in AMD are genes for important immunological proteins that function in your whole body, not just in your eye, but your whole body. So immunology is very important in AMD, and that is in good measure part of the genetic background for AMD. that increases your susceptibility of getting an AMD considerably. And as Michael said, smoking and a whole bunch of other things like that, environmental, increase your risk factor even more. So immunology and genes and gene mutations. Number 2, oxidative damage. We well know that it's very important. Oxidative damage is important in aging. It's why the muscles and skin in my face are sagging considerably in other parts of my body, maybe you as well. So oxidative damage is very important in aging. And what is AMD? It's a disease of aging. So another risk factor, another problem in AMD, another damage factor is oxidative damage. Whatever the damage initiator is, the immunological genes, the oxidative damage, it leads to photoreceptor cell death. And also, as in the primer that you just had a few moments ago, there's another important cell layer right next to the photoreceptors called the retinal pigment epithelial cells. Pigmented, they have little dark pigment granules in them. But as you heard from Dr. Brint, they're really important for maintaining photoreceptor cell health. If the pigment epithelial cells are sick or die, your photoreceptors are going to sick or die, and you will have AMD, whether it's dry or then progressing to wet or whatever. So cell damage, cell death, retinal pigment epithelial cell death, photoreceptor cell death as a result of either immunological or oxidative or whatever damage. And so the idea here is to prolong, we hope, the life of those cells, the pigment epithelial cells, the photoreceptor cells, maybe even replace them if we can. And I'm going to be talking about this. And then for as yet kind of an unknown reason, we really don't know why, what we get is neovascularization in some cases. And as you heard, that's only maybe 10% of the cases, but if you have it, it's really it can be devastating. And so the vessels leak, the new vessels, they hemorrhage, and they can cause photoreceptor and retinal pigment epithelial cell death. So now, derivative from, now you understand now what might be causing the underlying basis. There's more, but these are the main ones, the underlying basis of what dry or AMD really is. Derivative from these pathways then, these damage pathways, would be some major treatment possibilities. And the first, I talked about immunology, the genes involved in immunological proteins in your body. This is very difficult and very little progress is being made here, unfortunately. Everything in science I wish worked, it doesn't. And here we're at a stalemate because what we're talking about with these genes is they make proteins that are important in every cell of your body, the whole body. And so it's very difficult to treat in that way. So, we're understanding the immunological, the genetic basis, but we really aren't focusing yet on treatments here. Where we can focus, though, is for control of oxidative damage, antioxidants. We can look at then as well, and I'll come back to that in a moment. Remember I said that this type of damage will cause either photoreceptor or retinal pigment epithelial cell death. We can control that as well. This area is called neuroprotection. It's a whole big field now that is developed for brain, for retina. Protect neurons. The cells, photoreceptor cells, for example, in your body are neurons, just like brain cells. They're virtually part of the brain as such. So that area, neuroprotection, which I will come back to in more detail. And then finally, specifically for wet AMD, the control of neovascularization. And that's the important role there. And I'll very specifically talk about that. So let's take a closer look now. You know the causes. You know how to approach in general some of these diseases and their control. Let's start by taking a look at wet AMD. A main problem in wet AMD is that natural small proteins in your eye called growth factors, and there are many of them, and they're in all your tissues, but the ones in your retina unfortunately start to call in the new abnormal blood vessels. We don't know quite why, what that switch is as such, but that's the key in wet AMD. Going from dry to the wet. The new blood vessels come in because the growth factors suddenly become more robust, or more of them, or whatever, and call in the new blood vessels. So in wet AMD, as you would guess then, if we're talking specifics, control these growth factors. And then that might inhibit the biological activity in them. The most important of these growth factors is called, and I'm going to give you some technical terms that you may want to jot down or forget, or depending on what you want to do. The most important of these is called VEGF, V-E-G-F, vascular endothelial growth factor. It's a growth factor. That's the most potent one in your eye. That's the most potent one in the retina. And this is the one that we want to control. And you heard about two methods of controlling them from Dr. Brint, and that is Lucentis and Avastin. These are anti-VEGF. They stop the action of this growth factor, and so therefore the new blood vessels are blocked from formation. Or they may even regress. They may even retreat a little bit. And so this is Lucentis and Avastin that you've heard about already. This has been around for a couple of years now. Many of you, are you being treated? Hands up. Lucentis, Avastin? Oh yeah, a lot of you. There's the cost factor. In the United States, Lucentis is about $2,000 or so versus $200 or $20 for Avastin. And these are antibodies. These are cousins that inhibit VEGF. They bind to VEGF, stop its action, and the VEGF can't call in the new blood vessels. Hopefully this is clear, I hope. That's the basis of wet AMD. So what's new here? And you did hear, again, from Dr. Brint, what is relatively new. There have been two major clinical trials that compare Avastin and Lucentis for activity and for safety. And the one was the control of AMD treatment trial in the United States, and a cousin called Ivan in the UK. And what they found is that the action of the two drugs are pretty similar, enough that there's really no difference as far as activity is concerned. But what they found is that with Avastin, there might be a little bit of a risk systemically. So Avastin may not be quite as safe as is Lucentis. So if you're taking these drugs or thinking about it or whatever, talk to your doctor. Go and see Dr. Brint up here. Okay, they're covered. Sharon said, good. So that's what's kind of new as far as the Lucentis and Avastin story. But what's newer is, again, what was mentioned by Dr. Brint, in that there are alternatives now to these that may even be better in different ways. And one of them is called Eylea, E-Y-E-L-E-A, or VEGF trap, because that's what it is. It traps, inactivates this bad growth factor called VEGF. So the new thing about Eylea, about VEGF trap, is that, as you heard, instead of monthly or 6 weeks or whatever injections, you may be able to get away, and you should be able to get away with every 2-month injections, or maybe even more, spread out to 3 months or something. Of course, it's up to your own doctor, excuse me, to look in your eye and decide what course to take. But One of the good things about VEGF trap is the possibility of having the number of treatment, 1/2 the number of treatments and all. And then there are other growth factors in your eye. I didn't mention them. There's a number of them, not just this VEGF. And at least theoretically, VEGF trap is supposed to inactivate those other ones. So it may be better. You may be switching, again, as your ophthalmologist decides, from one to another. And with EYLEA, there may be these positive effects that will bring you over to that particular treatment. Now, there are some gene therapy potentials coming up. They're not here yet, but they're hopefully coming. And there are two that I just want to mention. There's one from a small company in the United States that I've been involved in a lot because I got to kind of work on and name and clone and fiddle around with this particular protein called PEDF, which is an anti-neovascular protein. It inhibits VEGF. And this company has had a clinical trial. It has finished this clinical trial. Genvec has, and PEDF looked pretty good. The oddity about this, and again, I'm not sure what's going on with the company. Sometimes the science doesn't work, as I said earlier, but here there seems to be some marketing problem or something else. I don't know what. None of us do. And the clinical trial has been finished for several months. They have announced that the safety was very good, but they're not marketing it yet. So we're just going to have to twiddle our thumbs and wait and see what's going to happen there. But you may be having another alternative to either the Lucentis or the Avastin, or VEGF trap for that matter. And then another clinical trial, which is in testing, of course. Clinical trials are the human testing. There's one called retinostat, and this uses two other inhibitors. Now it's not Avastin, it's not Lucentis, it's not PEDF, it's two other ones I won't even name for you. This is a British company, and they're well into clinical trial. And the results, from what I hear at least, the company is called Oxford Biomedica, in case you're interested. And you can go Google these, go to the websites, if you're interested in learning a bit more about these. They're in early phase clinical trial, so we don't have an answer, but they think it's going along pretty well. So besides the injections of the proteins into your eye, it may be that you'll be able to have a quick gene therapy treatment. This is still an injection, of course, and other drugs that might be even more important, that would work better. I want to tell you about two others here. This is all wet now. One is called focal radiation treatment. This sounds a little scary. I know it sounds a little scary to me because it's radiation. And they use a dose of radiation from the radioactive compound element called strontium-90. And what they do is this radiation they give focally on your eye, and it can kill the new bad blood vessels. They say specifically, and they say safely. And they have finished a clinical trial. They're done with it. And the result is that it's safe, and that it is, they say, it stabilizes vision. It doesn't seem to improve vision. But this technique is new. Everyone needs to look at it. I don't know whether Dr. Brint, he's smiling back there. At least he's awake. Thank you for being awake, Michael. But we'll have to look at this treatment. But it is certainly a possibility in the next couple of years. And then finally, the old and the new. It's called combination therapies. And one that I just read about a week or two ago, it's from a clinical study out of Japan, but the idea has been around for a while of putting together different treatments for a particular patient. Almost personalized medicine as such. And this one in particular is interesting. It's called triple therapy. They use Lucentis, That's the basis of it. That right now is our rock-solid treatment for wet AMD. And then these patients also get an injection of steroids, which are mildly anti-neovascular. Steroids tend to stop new blood vessels, but it's not a really good treatment. And then they add in a third treatment called photodynamic therapy that Dr. Brint mentioned to you. That was the first therapy out. It really didn't work well, and they were real lucky that they were out first because they made a lot of money because they were the only therapy in town as such. So these people are using 3 different therapies together. And I want to read here. It says, this study reports, quote, significantly improved visual acuity, a need for fewer treatments, and also far fewer complications. So again, along with Lucentis, Avastin, and those wet AMD, this is, of course, there may be these types of combination therapies in the future. Let's take a look now at dry AMD. Enough of wet AMD. There's a lot of potential treatments coming. There's a good one, Lucentis, and other ones that are coming, such as the combinations that those of you who have wet AMD may have in the future. Now, 90% of you have dry AMD. The wet form is only a small percentage. And here, mainly, there's a slow death, as you heard from Dr. Brint, of the photoreceptor cells that may be caused by the dysfunctioning and death of the adjacent, abutting retinal pigment epithelial cells. But when at least some photoreceptors and RPE cells are yet alive, we can use neuroprotection to protect the neurons, and we can use antioxidants, and there is the possibility of stem cell therapy as well to keep the photoreceptor cells alive. So let's take a quick look now. We're on dry. I'm going to talk about neuroprotection. Neuroprotection is simple. Protect the neurons. Photoreceptor cells in your eye are neurons, just like in your brain. And if we can make them live longer and maybe even function better, all the better. Then we're staving off the disease process. And there are many proteins, natural proteins in your eye that are called, again, growth factors or neuron survival factors, neuron survival agents, many of them. And then some that are not quite, they're man-made, they're not even natural. And there is a trial on one of these growth factors. It's called CNTF. Again, you don't have to remember any of these names or whatever, but if you want to, it's called ciliary neurotrophic factor, CNTF. It's one of the most prevalent and one of the most important factors that keep neurons. Right now, they're working in your brain, they're working in your retina, to prolong the life and make the photoreceptors work better. So with neuroprotection, is there a clinical trial that's going on? And the answer is yes. There is a clinical trial from a small company in the U.S. and all on neuron survival agents. What's the one I just mentioned? CNTF. You remember that, hopefully? That's the one that they're testing. It's a growth factor, it's a neuron survival factor, and they're testing it across the spectrum of the retinal degenerative diseases. One of the parts of their clinical trial is for dry AMD, one is for the rare retinal degenerations, and then one is for retinitis pigmentosa. And in it, they have a small capsule that they put in the eye of the patient, a tiny capsule close to the retina. And within the capsule, there are some cells that are specialized to produce CNTF. Remember, the growth factor. The CNTF leaves the capsule, enters the retina. What does it do there? It helps to protect the photoreceptor cells. So it's a neuroprotection type of therapy. And so what's going on is that the clinical trial for dry AMD is looking pretty good. They're not finished, so this is not available yet, but it should be available soon. And it's my feeling, because I happen to know the people there extremely well, is that this should probably be, within a year or two, the first general treatment for almost all forms of retinal degeneration. Again, dry AMD, the rare retinal degenerations such as Usher's or Stargardt's or whatever, and then the forms of retinitis pigmentosa. There are many of these other natural proteins. Where are we going in the future here? I just mentioned one. There are at least 30 other ones besides CNTF. And with that, we need to test them. We need money. We need the foundation to work with basic researchers to increase our knowledge of these other neuron survival agents, and then we need to go to clinical trials. So we have a lot of the information as to what direction to go. Unfortunately, right now it's theoretical, and the clinical trials are not in place. So that's neuroprotection. This is the use of neuron survival agents. Antioxidants is the other big area that we need to talk about, and you heard again a little bit this morning about it. It's clear that antioxidants work in mid-stage dry AMD, not wet, not early dry, not late dry, but the clinical trial says mid-stage dry AMD. That doesn't mean that they don't work in the other forms. It just wasn't tested. But as you heard earlier, the AREDS trial, AREDS, Age-Related Eye Disease Study of the National Eye Institute in the U.S., gave patients the antioxidant vitamins C and E, beta-carotene, and the mineral zinc, which seems to rev up antioxidant proteins in your body, ergo the zinc. Now, a few years ago, another study, was a good friend of mine, Dr. Theo van Veen in Sweden, fed animals with retinal degeneration a special other combination, not the AREDS combination, but other antioxidants. These were for retinitis pigmentosa animal models, not AMD yet. And he was able to dramatically slow the course of the photoreceptor cell death. Together, he called these retina complex. One word, retina complex. And if you're interested, you can go to your computer, Google retina complex. They have a website, and interestingly enough, it's already for sale over the internet, which you cannot do unless you talk to your ophthalmologist first. But they do seem safe. A lot of people for about 2 years across the world have been taking this. The company is in the Netherlands. And from that, this animal study, this preclinical study ended a year or two ago. A clinical trial in Spain, very small clinical trial, has taken place on retina complex. And it's been pretty successful. So again, small clinical trial. Now we need to move to bigger clinical trial there. And this is probably going to be an alternative for you in the future, at least for dry, if not wet, for AMD. There are other antioxidant trials that are going on. Dr. Rint mentioned AREDS 2, the number 2 clinical trial on lutein and zeaxanthine. Some of you may already be taking these. They are natural yellow pigments. They come from plants. It's what makes squash yellow, corn yellow, for example. And they belong to what is called the carotenoid family. The carotenoid family has a lot of antioxidants in them. And when ingested, lutein and zeaxanthine are concentrated in your retina and the macula. Makes your macula region in your eyes now yellow because of the concentration of lutein and zeaxanthine. And as you heard, this is being tested by the Eye Institute with another potential important antioxidant called omega-3. This is a fatty acid. This is an omega-3. It depends on where some of the chemical bonds are. And it's a long-chain polyunsaturated fatty acid, omega-3. There's another trial that has finished, but has not gotten a lot of press, and I don't understand why. It's called the Women's Antioxidant and Vitamin B Study. I don't know where it leaves men, but at least for women, might be good. In the study, they didn't start off by looking at AMD. They were looking at cardiovascular disease in older women. And what they found is that the women who were taking supplements of vitamin B were greatly protected against AMD. This was serendipitous. This was an odd finding. They weren't looking for it and all. And again, I don't hear a lot of my ophthalmological colleagues talking about women take your vitamin B, or even the men as well. My wife gives me a whole range of things every morning to take, and I'm pretty sure one of them is still vitamin B. So what I'm aiming with this is there are other antioxidants that are either in place or coming that are going to be very important in the future. Now, I want to turn a little bit, to an area that some of you with very poor vision, terminal stages, geographic atrophy and whatever, what do you do when the photoreceptor cells are dead? You don't do gene therapy. You can't use antioxidants. You would have to resuscitate your photoreceptor cells. So here we would use treatments that would either, and these are ones here now, some other coming, that could either replace the dead photoreceptor cells or at least replace their function in the retina. And the first would be transplantation of natural photoreceptors or the use of stem cells. I think we all missed this morning a wonderful talk, I'm sure, by Dr. Van de Kooi, who's a leader here, an international leader on stem cells. And then the second would be the use of electronic prosthetic devices, what's called artificial vision. So let's first consider photoreceptor transplantation. You may ask, okay, lots of transplantations are there. Hearts, livers, kidneys, whatever. Why not photoreceptor cells? Why can't we just transplant in photoreceptor cells? Well, this is very difficult to do and has shown very poor results in animal models. The reason is that photoreceptors are neurons, just like in your brain, and you don't often hear of brain transplants, although you may know people who need brain transplants, possibly. But photoreceptors are neurons. They don't transplant easily. There was a clinical trial in the United States that's concluded now, very small, Dr. Norm Radke, and he did RP patients. He didn't do dry AMD patients. It was not successful. It just really didn't work. And so this whole area, and I'm only covering it because I'm sure you've all thought about this possibility. Again, everything, unfortunately, in science does not work. But we have an alternative, and that is the use of stem cells. Stem cells are primitive. They may or may not come from embryo. Each of us sitting here have some stem cells in their retina, and they can be harvested. And animal studies are going on, and I want to tell you just about one of them. And this is a really important animal study. Again, not useful for us clinically probably for 5 or 10 years, but human embryonic stem cells were taken and put in the eye of a mouse with a bad form of retinal degeneration where the photoreceptor layer is just decimated, gone. And there was restoration of vision. Not wonderful, but not so bad in the mouse. So what you might guess is that those primitive stem cells were converted to photoreceptor cells, integrated into the rest of the cells in the retina, and voila, vision. They were able to take the light image back down to the brain, into the visual areas of the brain, and this is the first example that I know of the use of stem cells in an animal model. This is not dry AMD yet, this is RP, but it's replacing the photoreceptor cells, and it's working. And if it works in retinitis pigmentosa to replace the photoreceptor cells, we really think it should work in dry AMD. So I'm very excited about this work. It's work of Dr. Tom Ray at the University of Washington in Seattle. And the last area I want to talk about is, again, restoration of vision, one of the big directions and goals of the foundation here, not only in preserving our vision, but in restoring it when things have progressed to end stages. And that's the use of the electronic prosthetic device. I've been involved in working on that for about 8 years now. I am not the originator. It's a brilliant MD, PhD at USC by the name of Mark Kumayan. And it replaces the function of the dead photoreceptor cells. You know, they're not replacing the cells themselves, but there's an electronic gizmo that goes in the eye that replaces the photoreceptor cell function. The design is simple. The patient will wear a video camera, tiny little video camera, probably on glasses, in the middle of the glasses or something, perched on his nose or her nose. That will capture the light image. Video camera. It's simply a video camera. And convert the light energy to electronic energy. That goes to a computer, usually a little mini computer on the belt of the patient, excuse me, where it enhances and processes this electronic signal, which then passes back into the eye to a chip, an array, just a little grouping of electrodes that are on the remaining cells within the retina. Photoreceptors are gone. This sits there on top of the retina and the other cells, and it passes that signal, that electronic signal, to the rest of the retina. Down the optic nerve to the brain, to the visual parts of the brain, and voila, vision. And so this is really the newest thing as far as what's going on. So I want to say that this is not restoring perfect vision to these patients, but the patients are going from bare light perception or no light perception to being able to figure out the difference between a knife, a cup, and a plate on their dinner table, or looking at the hash marks at a pedestrian crossing and recognizing them. So they're going from virtually no vision to functional vision. They're not reading Macbeth or anything else like that yet, but this is in the future. This is hopefully for the future sometime. It's available now. The clinical trial has finished in Europe. It's available for purchase. It's very expensive, but hopefully governments see the light as such and will subsidize this for patients. It has not been used in dry AMD patients. Certainly not. This is not for wet AMD, but it's not been tried in dry AMD patients. But because the focus here is on photoreceptors, we all think that, and including this company that is marketing it now already, that this will be applicable to dry AMD patients. It will be applicable at end or terminal stages in dry AMD when there's very little light perception or none remaining. But it should restore, just as in retinitis pigmentosa, it should restore, at least theoretically, vision, some functional vision to dry AMD patients. So, in summary, we now have two scientific paradigms. They're not wonderful, but they work, and they treat AMD. The first one you heard about this morning and then from me is the use for wet AMD, the use of anti-VEGF, remember VEGF compounds, Lucentis, Avastin, Eylea, some of the other ones that are coming, the PEDF, the things like that, to control the new blood vessel formation. And so other treatments here are coming. Now, stay tuned as such. For dry AMD, we have the ARADS antioxidants. They work at mid-stage. They don't seem to work. Well, they really, they may or may not work, but clinically it doesn't look like there's much good for early or very late dry AMD, but they do work. But other antioxidants, stay tuned. again, I don't know why we're all not on vitamin B, for example, even men, much less women. And so a lot of these, retina complex looks really good in animal models of retinal degeneration. These are very safe compounds. Apparently you can not overdose on them. The worst that will happen is they will pass through you and you will fertilize your toilet bowl, basically. But no damage as such. So that's now. We have a couple of treatments. Looking to the future, many other clinical trials. Some I didn't even talk to you about. There have been transplantation trials, for example, that I didn't even mention. These are starting and they're progressing. The use of stem cells is looking very good for producing new photoreceptor cells and even retinal pigment epithelial cells. I hardly touched on this as such. And hopefully, along with these new things that are yet being tested, we have the retinal prosthesis. Again, only tested and available for RP patients, but we're hoping, and certainly the company is hoping, because of the much larger number of people with dry AMD than with retinitis pigmentosa, hoping to be available in the next year or two. And there is some negotiation, from what I'm told, from a good friend of mine in the Second Sight company that is marketing this Argus prosthesis, that they are negotiating for sight, and I think it's right here in Toronto, for implantation with this. So we hope that these treatments, through the FFB, are going to be leading to ways to cure AMD instead of just slowing its course. And then finally, we hope one of these days we're going to find the Holy Grail to prevent AMD from even starting, and putting people like Dr. In the back out of business. So we're hopeful for that. So a few things available now, several more things coming. Stay tuned to the foundation. Thank you for your attention.